TopMedTalk.
Welcome to Perioperative Enhancement Teams. This TopMedTalk series is about the importance of value-based care, which puts quality at the heart of everything you do. In this programme, we're going to be looking at pre-operative smoking cessation clinics. Also, could you use a specialised centre for geriatric surgery and palliative care? And the rise of CPET, cardiopulmonary exercise testing. Before that though, what is the relationship between enhanced recovery after surgery and prehabilitation?
To me, prehabilitation has always been a very great idea that fits extremely well with the enhanced recovery ideas that we have been developing over so many years now.
Ollie Lukvisk, Professor of Colorectal Surgery from Karolinska and Åbo University, and the Chairman of the ERAS Society.
It has several of the basic components that fits with sort of the fundamentals of ERAS, which is, controlling stress reactions, improving the way that the body can react to surgery and cope with surgical stress through nutritional, functional, metabolic manipulations, but also adding to that, which I find very interesting, the mental aspects, which is new, I think, for many of us. To me, this adds a very important and interesting component to the entire concept of ERAS. So for me, it would be a natural part and part of a very interesting development of ERAS for the future.
So are we getting into ERAS 2.0?
Yeah, I think we are in some respects. I think we're learning a lot as we're moving along. We're broadening our ideas. But this one, I think, with knowing Franco for many, many years, I think his interest and mine have been very similar over the years. So I've been fully buying into the ideas behind this from the very beginning. And I'm just very pleased to see that it's now developing into randomized trials that we've heard about, actually showing outcome data in a very positive way, which one really could suspect, and now it's coming. So I think it's going to be a very important next step for enhanced recovery as well.
Enhanced recovery after surgery is enhanced by proper preparation before surgery. In fact, you could argue it's all part of the same perioperative process. The moment you start thinking about having an operation is the moment you should start preparing for the operation.
In a way, we always compare with a marathon runner, right? For a marathon runner, if you prepare yourself for a marathon runner, definitely you have to train.
Professor Frank Francesco Carli, Professor of Anesthesia at Amica University in Montreal.
Or whatever, any event. So that makes sense that you prepare it. Now, the question is interesting is that ERAS, in my view, had not addressed this issue in the past. Has been addressed the issues of very much the pre-operative, immediately perioperative, except for the education component. Now we have an opening, right? Pre-op. But I think the excitement is to really looking forward the post-operative, that's another missing target, which I think the post-op will be the result of what actually happens in the pre-op. So if we do well before, definitely we have an impact on, call it outcome, disability.
Before we go deeper here, it's important to emphasise the essential multidisciplinary aspect of this work. Amir Jaffer, Chief Medical Officer for the New York Presbyterian in Queens, founding director of the Perioperative Medicine Summit, explained how important it is to include mutual respect in the daily workings of your practice. In his words, it's about giving everyone the chance to have their say.
The leaders felt that if we don't have respect, we really can't do anything. You can't have teamwork if you don't have respect, and you really can't do the things that you really need to do in healthcare, because healthcare is really a team sport.
Yeah.
And so we started there, and then we basically took it to the front lines, and we talked every single day about respect. We took examples of respect that employees would come up and talk about, or disrespect, that they'd been disrespected. By talking about it every single day, then we had a major employee retreat at New York Presbyterian Queens a year later, which was also focused on respect. And now the enterprise, which is 40,000 employees, decided very recently over the last couple of months that they would have a chief respect officer. if you don't have respect, you basically can't do anything, right?
Yeah. So, what is the chief respect officer? What powers do they? How do they? Let's imagine someone's acting up and just won't show respect.
Yeah.
It's deep in their DNA to be a pain in the whatever.
So I'll just tell you that even before we appointed a chief respect officer at our organization, we were well underway on this journey. And so when reports of disrespect got up to our leaders, they had the ability to actually remove and fire individuals.
You said that during your presentation. I was amazed.
Yep.
Wow.
And
it works. I mean, it
works. It works.
Yeah.
In addition to this, there are daily huddles, which provide a structured approach to get information up to the leadership. Currently, these huddles are broken into 3 tiers. The first, Tier 1 huddle, happens at the unit level. Clinicians, nurses, doctors. Amir explained to us that they have a huddle board. They have a structured approach to spend just 10 or 15 minutes together reviewing all sorts of information, perhaps even information from the previous night. And from there, this information is then fed up to the directors, their Tier 2 huddles, and then the directors bring that information to a leadership huddle that occurs at 10 a.m. every day.
How long do you allocate for it?
It's usually 15, 20 minutes.
Yeah. Do you do it standing?
Yeah, well, half the people are standing.
Yeah.
People who come earlier grab seats.
Yeah.
But it's usually no more than 15 or 20 minutes. The other part, Monty, is that we always end with recognitions.
Yeah.
And we always start with overnight safety events and good catches. So, talking about the transformation that's needed to get to zero harm, we want to recognize people who actually identify problems before they affect patients, right? Before the problem, in fact, hurts a patient. If people identify a problem, that's considered a good catch. And we actually give them a pin to recognize them.
So you actually award people for doing the right thing when normally you would probably feel intimidated in most organizations.
Right.
Yeah.
And then at the end, we always identify situations where people have gone above and beyond, and we recognize them openly. So it's really started to this culture where things are transparent, where people feel like things are fair.
Safe zone, too.
Exactly. They feel comfortable speaking up, and just the positive reinforcement has also helped create a really nice culture.
I'm guessing that 15 to 20 minutes standing cuts out about 5,000 emails.
Yes, yeah. I have to tell you that definitely we don't get a lot of emails around these issues because they get solved in real time.
Wait for 10 o'clock.
Yeah.
And just get
it all out.
Get it done.
I definitely feel it's great. It's really, really helped the communication.
One more question on the huddling. Do the huddles that take place on the rock face on the floor, do you do them in public? Or do you go to a private room? And the reason I ask
the ones on the floor? Yeah. Well, no, it happens right in the unit.
Yeah, so
right
patients. Perfect.
So usually, you have patients who may be walking by. If the patient actually happens to be walking in the corridor and there's a huddle going on, if they want to observe, they're welcome to observe. We usually don't take patients' names and stuff. So if we need to, we ensure nobody's around.
I think that's a very positive step as well.
Transparent, yeah. I love this theme, though, that for everything that you've been talking about is getting employees, your team involved from the bottom up, top down. Because so many of these initiatives, they come from the top, but they don't do anything with the people that are actually the ones that are having to communicate and having to, do the change themselves. And so, I think that's such an important part of transformational change and change management.
Absolutely.
That gets forgotten.
Absolutely. Like you said, you got to make sure that the front lines are involved in the change. You hear from them. And, what's really, really striking, exciting about the huddle is that anybody who's there can speak up
Yeah.
afterwards to recognize their peers. And then we go down every item. So whoever is the lead for that area, will speak up and tell us if there's any issues.
Also today on TopMedTalk, CPET.
CPET, cardiopulmonary exercise testing. It's an objective way of measuring aerobic exercise capacity. The original formulations were used mostly for diagnosis of unexplained exercise intolerance.
John Whittle, Assistant Professor of Anesthesiology and Critical Care Medicine at Duke, here in conversation with Monty Mython and Desiree Chappell.
Especially if you imagine sort of back in the 60s, prior to echocardiography, other tests, other imaging tests that were kind of possibly more prevalent now, particularly in the cardiology world and the pulmonology world. It was a good way of diagnosing limitation, cardiac, pulmonary. It's an integrated test. So, when you get on an exercise bike and you cycle against increasing resistance, then you stress, all your physiology. So right from the mitochondrion up to delivery of oxygen to the mitochondria, up to the macrocirculation, the heart, and then lung efficiency. So air, oxygen in, carbon dioxide out, simply put.
John, I know the majority of hospitals in the NHS have got a CPET service now. Do you know where it's gone to? Latest figures from poets from the society?
I think Denny was saying 70 to 80% last time I spoke.
Higher.
Yeah.
70 to 80% of hospitals in the NHS have a CPET program.
Yeah.
Wow.
It's the largest users of CPET in the United Kingdom, and it doesn't really seem to exist here for perioperative use.
No.
Maybe very sporadic.
It's used here.
Yes.
Because the original training for cardiopulmonary exercise testing from the people from the UK was done in Southern California.
Correct.
So that's
and it was developed here,
and
right?
the original books all about it are all from Southern
Wasserman.
Yeah, exactly.
Wasserman.
The Bible.
The Bible. Yeah. 1960s, right? The original metabolic carts and using Douglas bags and so on here in the United States, and it is used clinically here.
Yeah. You've got equipment at Duke before you.
We have equipment at Duke. The cardiologists do a few. Pulmonology, all the pulmonologists I've talked to at Duke had some exposure.
It might help, John, if we describe what happens back in the UK when you turn up to a pre-op clinic and someone says, we're just going to do your cardiopulmonary exercise test now.
Yeah, the process is simple. It takes about half an hour. You turn up, but there's a brief questionnaire about whether we're going to make you fall off the bike, i.e., just a few medical questions about unstable angina and those sorts of things. Things that maybe we don't want to stress.
Maybe relevant somehow. Yeah.
And then the test itself, basic height, weight, some spirometry to help produce some predicted values for respiratory parameters. And then you sit on the exercise bike, and the exercise bike is connected to what's called a metabolic cart. A metabolic cart actually does quite a few things that our anesthesiology and anaesthetist listeners will recognize, i.e. has a carbon dioxide measuring device, an oxygen measuring device, so paramagnetic oxygen analyzer, an infrared oxygen analyzer, measures in and out carbon dioxide oxygen usage, a flow meter, a turbine, and we've probably all seen on some television advert at some point an athlete being exercise tested with the blue mask on, the little turbine in front of
Usually
their...
on a treadmill.
Normally, often on a treadmill. And in fact, we could talk about that a little bit more. But with this mask on and they're being pushed to the limit, and there's a very suave and sophisticated exercise physiologist standing next to them.
Because they all
interested. Because they all are.
I turn up.
So you turn up. You turn up. We're going to put a 12-lead ECG on you. We're going to put a saturation probe on you. We're going to put a blood pressure cuff on you. We're going to put this mask on with the turbine in front of you.
And the bike looks like an exercise bike.
And the bike looks like an exercise bike in the gym.
Gotcha.
So you sit on that. Next to it is a trolley with some measuring equipment on and a couple of computer screens. Then we just get you to sit there for a few minutes, get some basic baseline recordings, ECG, what your baseline breathing rate is, etc.
There are some videos on YouTube about this.
Actually, the UCL Centre for Anaesthesia have a series of CPET.
Yeah, we'll find those links and put them up.
Yeah.
On the other hand, could your value-based care proposition be further enhanced by a centre for geriatric surgery and palliative care?
It's being headed by a surgeon who's a woman surgeon who's boarded both in surgery and palliative care. She's one of the few surgeons in the country that's boarded in both surgery and palliative care.
Angela Bader, Professor of Anaesthesia at Harvard Medical School and Vice Chair for Perioperative Medicine in the Department of Anaesthesiology Perioperative and Pain Medicine at Brigham and Women's Hospital.
And she and I run a research group, which will be the research arm of this center. But the goal is really to focus on identifying geriatric patients that can benefit from preoperative interventions. And this is the pre-op clinic is one piece. I think this is trying to take it to a new level. So this literally, we're just having the first meeting, so we're trying to put this together from an organizational perspective. And I think what also is very nice is it's a multidisciplinary effort that involves geriatrics, palliative care, anesthesia, and it's going to live in the Department of Surgery because it's really a surgical initiative, which I think is one way of hopefully ensuring hopeful success, because with surgeons actually being involved in starting it, I think that surgical buy-in is going to be less of an issue. I think they'll be much more welcoming.
Yeah, I got a little skin in the game on this one.
Exactly.
So it's the specialist care of the elderly surgical patient has become relatively common, and we've interviewed numerous...
so the POPs.
But it's the palliative care twist that I haven't heard before.
Exactly.
Yeah. Can you expand on that bit?
Sure. So as Monty knows, because he was kind enough to have me lecture several times on this topic, I am very, very interested in high-quality shared decision-making. And Zara Cooper, who's the surgeon who's starting the center with me, we really need to have the mindset changed so that sometimes not doing surgery is the right
answer.
And as Amir said earlier, we are in this crazy race where everything is based on volume. Yep. So we really need to get away from that and really focus on value, which is patient-centered outcomes, over cost, instead of just doing the volume and not really caring what happens 2 months, 3 months, 4 months.
Could your patients do with mini cognitive tests? Angela explains.
We're very interested in elderly patients with cognitive dysfunction. And most clinics, at least in the U.S., don't even measure it. Do you measure that in the U.K., cognitive function preoperative?
Not universally. So it's recommended now. And we, the clock face idea, the three things, the mini cog idea is often talked about, but not reliably universally delivered. I don't think it will be that long until it becomes standard.
Right. So
people are listening.
Right.
People are listening.
Yeah, right. So too.
So I think, just to summarize very briefly for those who may not know, so we did some research. Surprisingly, it was the first time somebody actually looked at a preoperative population above age 65 and did standard mini-cog evaluations. And what we found, which was actually published in Anesthesiology, if anyone's interested, 2 publications.
Okay.
The first one showed that overall there's a 29% incidence of previously undiagnosed cognitive dysfunction. That's huge.
Yeah.
And if you were above age 75, it was 40%.
Wow.
And this is eliminating people that had a diagnosis already. So I feel like we've turned over a rock, and now what are we going to do with the results? And then we did a follow-up study which showed that people with previously unidentified abnormal cognitive stratification have longer lengths of stay. More of them go to a facility instead of home, and they have more complications. So it matters.
It does.
It matters. And it's a huge burden. And so now that we've sort of shown this, we have to figure out what to do.
So what is the next? I mean, what are you guys doing for the next?
I think it's a center for geriatric surgery.
Yeah, of course.
Well, it's not just having a center. What it is a population management where you identify these groups at risk, and you have a preoperative plan of how you're going to deal with that specific patient's issues, whether it's cognitive issues, frailty, etc. Now, you may be familiar with, I'm sure Monty is, that the American College of Surgeons has come out with new guidelines for how geriatric patients should be taken care of, and I don't think most institutions actually will meet those guidelines because they involve cognitive testing and all of this attention to things that in most cases all we cared about was doing the
Looked
volume.
over.
Don't even, just get the patient in, do the volume.
Yeah.
And then especially when patients are in situations where you don't have a pre-op clinic,
how do you even how can you even
they
manage?
ignore it. So I hope that and the reason they ignore it is because we get paid for doing the case.
Yeah.
And there hasn't been motivation to think about really optimizing preoperative care and having a goals of care discussion.
Well, I think so many times too, we never really look at our patients for the anesthesia world.
I know.
We don't look at our patients post-operatively.
I think
there's not a lot of follow-up, especially if you're not in an academic setting.
Right,
exactly. You're not doing that. And so I think that's part of it too. They're fine when I drop them off.
Right. Well, I don't know, Monty, what you think the U.S. versus the U.K., but I think one of the big problems is that anesthesia people in training don't learn that this is important.
Yeah.
Do you teach that in the UK training?
We hope big time.
Yeah, see, that we're really missing. So I've been doing...
And I think the med students are getting it now much better as well.
Well,
do you think it's still behind here?
Oh, God. Well, I went to medical school at Harvard. We didn't learn it then, and the medical students I teach say it's not
still
any
not
different.
In it.
Right.
Oh, man.
So roughly speaking now, surgery in our institution is taught around a spine of perioperative medicine.
That's wonderful.
So that's the spine of the surgical training.
Yeah, that's what.
And those issues are mainstream discussion points.
Right.
And certainly in anesthesia training, it's mandatory now to do the shared decision making.
Right, exactly.
Understanding the challenges of the elderly surgical patients and end of life decisions.
Right.
We're now going to consider the possibility of a smoking cessation clinic, which could be the next step in perioperative enhancement at your practice. Here's James Davis, Director of the Duke Smoking Cessation Programme, outlining how that might work.
What about smoking and perioperative outcomes? I would say at this point the case is quite strong that smokers do worse in many domains than non-smokers. This is a trial. I forget. This is a meta-analysis looking at lots of trials, and I think it was 25 trials on this one, 22 or 25, nearly 3,000 patients, and comparing smokers to non-smokers. And we have in the perioperative in the postoperative period, and so we have septic shock. We see an odds ratio of 1.4, sepsis 1.38. Bleeding and transfusions crosses the confidence interval line of 1. Cardiac arrest, we see stroke, ventilated time, unplanned intubation, pneumonia. 30-day mortality is up 30%, and any major morbidity, so altogether, looks like about 50%. So I think that there's a very strong case now that non-smokers do better than smokers in terms of their operative outcomes. This is another study. This kind of looked at 95 different studies, and there were about 12 that fell in that gave this information. I'm not going to go through all the numbers, but this is from 2016. It looks very similar to the 2011 numbers. Now, the other question, which I think is really relevant, is if we ask people to quit smoking before surgery, does that actually make a difference? And I think the data now is starting to emerge that is fairly strong there as well. This was a meta-analysis of 9 randomized trials on quitting smoking before surgery, and looking at all postoperative complications. There was a 22% drop. And that included pulmonary complications and wound healings. Some of these studies had very short periods of quitting before surgery, and some were over 8 weeks. One of the findings with this meta-analysis is that if you quit for a longer period before the surgery, then that really makes a difference. So again, I think that the evidence is growing, and it seems to be more and more consistent that quitting smoking before surgery is really beneficial.
TopMedTalk.
Thanks for listening to TopMedTalk. Don't forget, of course, if you want to check out any of the information in these conversations in more detail, check out the show notes, and don't forget to subscribe to TopMedTalk right now.